Have you ever had that really weird, persistent tingling? Or maybe numbness in your hands or feet? Maybe even a strange burning feeling that, well, you can't quite pin down. It can feel pretty unsettling, you know?
Yeah, like your connection is just a bit
Yeah.
off, or maybe you lose sensation sometimes. Makes doing simple things feel, I don't know, clumsy.
Exactly that. Well, today we're doing a deep dive into the condition often behind these sorts of things, peripheral neuropathy.
And we're using a set of MSRA revision notes as our guide. So the plan is basically to unpack that material, pull out the really high yield stuff,
Yeah.
and lay it out so it's clear, memorable, and useful, whether you're revising for the MSRA or honestly just want to understand the condition better.
That's the idea. Turn those dense notes into something practical. I'm actually really keen to get into the details, understand what's happening biologically.
Great, and I'm ready to help guide us through, starting with the basics and building up. So let's just jump right in.
Okay, let's do it. So, starting right at the beginning,
Mhm.
what exactly is peripheral neuropathy, according to these notes? What's the fundamental definition?
Okay, so at its core, it's about damage or, well, dysfunction of the peripheral nerves,
Okay, peripheral meaning.
meaning the ones outside the brain and spinal cord. Those are the central nervous system, the CNS. The peripheral nerves are like the body's wiring,
Right.
carrying signals back and forth between the CNS and, well, everything else, muscles, skin, organs.
The communication lines, essentially.
Exactly. And the damage isn't always the same. It might just hit one nerve, that's mononeuropathy, or more often it affects multiple nerves, which is polyneuropathy.
Oh, yeah.
And the symptoms vary hugely because it just depends entirely on which nerves are involved. Are they sensory, motor, autonomic?
Makes sense.
The notes do highlight that it often starts out in the extremities. Hands, arms, but especially the feet. That's really common.
That clicks, doesn't it?
Yeah.
Why people first notice it in their feet or hands. It's the furthest point of the wiring, kind of?
Pretty much.
So what causes this wiring to get damaged? What are the main culprits that the notes list?
Well, there's quite a list, which tells you it's not just one thing. Diabetes mellitus is huge. Diabetic neuropathy is incredibly common.
Right.
Then there are autoimmune disorders like Guillain-Barré syndrome, where the body's own immune system basically attacks the nerves.
Wow, that seems like such a fundamental mistake for the body to make.
It's a serious problem, yeah. Other causes include infections, think Lyme disease, HIV. Nutritional deficiencies are important too. Vitamin B12 deficiency is a classic one they point out.
Okay.
Then exposure to toxins, alcohol is a big one. Certain medications like chemo drugs can do it. Also some inherited genetic conditions. And of course, physical things like trauma or nerve compression.
So a real mix.
Definitely. And the notes really stress this, finding that underlying cause. It's absolutely crucial for figuring out the right treatment and, the prognosis.
Right. So the why really dictates the what next.
Yeah.
Building on that, what makes someone more likely to get it? What are the risk factors mentioned?
Yeah, there are clear risk factors. As you'd guess from the causes, diabetes is probably the biggest one.
Number one, yeah.
Excessive alcohol use is another major one. Being on certain meds, like we said, some chemo drugs. Vitamin deficiencies, especially B vitamins.
Mm-hmm.
Having an autoimmune disorder already. A family history can play a role too, suggesting genetics or maybe shared environment. Oh, and the notes also mention things like repetitive movements or jobs involving chronic nerve pressure.
So it's a combination of health issues and maybe lifestyle or environmental factors.
Okay, let's go a bit deeper. How does the damage actually happen? What's the pathophysiology? What's going on at that nerve level?
Well, it really depends on the cause. So for diabetes, the notes explain that high blood sugar over time can damage the tiny blood vessels that feed the nerves.
Cutting off their supply.
Kind of, yeah.
Yeah.
Starving them or disrupting their function. In autoimmune conditions, it's the immune system itself attacking the nerve fibers or their protective coating.
Okay.
Toxic substances might directly poison the nerve cells or mess with their internal workings. So it's not just one mechanism of damage.
Not at all. The notes summarize the main ways it happens. Inflammation, obviously. Then demyelination, that's damage to the myelin sheath.
The insulation around the nerve.
Exactly, the insulation. Damage that and signals slow down. And then there's axonal degeneration, which is damage to the nerve fiber itself, the axon.
Right.
Any of these, or a mix, disrupts how signals travel. And that's what causes the symptoms we see.
Okay, that helps clarify the how. Now, the notes also differentiate based on whether it's mostly motor or sensory nerves affected. Can you break that down with the examples given? That seems like high-yield stuff for revision.
Absolutely. It's a useful way to categorize them. So you can have predominantly motor loss nerves controlling muscles are the main issue, Or predominantly sensory loss nerves for feeling are primarily hit.
Okay, what are some key examples of predominantly motor loss conditions from the list?
Sure. The notes mention Guillain-Barré syndrome, porphyria, lead poisoning, those hereditary sensorimotor neuropathies like Charcot-Marie-Tooth.
Right, CMT.
Chronic inflammatory demyelinating polyneuropathy, CIDP, and diphtheria. In these, weakness is usually the big thing.
Got it. And for predominantly sensory loss,
Mm.
where feeling is the main problem.
Key ones, there are diabetes, uremia, leprosy, alcoholism, that vitamin B12 deficiency again, and amyloidosis. Here, you're mainly looking at numbness, tingling, pain.
Okay. Now, the notes pull out alcoholic neuropathy and B12 deficiency specifically. What's important to remember about those two?
Good question. Yeah, they show specific patterns. For alcoholic neuropathy, it's kind of a double whammy. There's the direct toxic effect of alcohol on the nerves and the nutritional problems that often go with it, especially low B vitamins from poor diet or absorption. And a classic point mentioned is that the sensory symptoms, the tingling, numbness, usually start before the motor symptoms, the weakness.
Okay, so feeling changes first is a clue, maybe, towards alcohol.
It's definitely something to consider. Now, vitamin B12 deficiency, the notes highlight something very specific. Subacute combined degeneration of the spinal cord.
Okay, so involving the spinal cord, too.
Yeah. Yes. And the really key point here, like a good memory hook, is that the dorsal columns of the spinal cord get hit first.
And they carry?
Proprioception, your sense of where your joints are in space, and vibration sense. So someone might lose their balance or can't feel vibration before they even notice the typical pins and needles in their hands and feet.
Wow, that's a critical distinction. B12 isn't just the extremities. It hits those specific spinal pathways first. That's gold for diagnosis. So, tying this back, how do these specific types relate to the general symptoms we started with?
Well, they explain the pattern. That common start, especially with polyneuropathies, is often symmetrical pins and needles, numbness, maybe those odd, unpleasant sensations, dysesthesia.
Right.
Usually starting distally, toes and fingers, in that glove and stocking pattern, and then creeping upwards.
Yeah.
And the notes really hammer home that managing the underlying cause, like getting type 1 diabetes under control if someone's not compliant, is just vital to try and stop or slow down these symptoms developing.
Makes sense. Okay, so it presents in many ways. Given that symptoms can overlap with other issues, what else do doctors need to rule out? What's on the differential diagnosis list?
Good point. You always have to think broader. The material lists key things to consider. Radiculopathy is one that's nerve root irritation, often near the spine, like sciatica.
Okay, a pinched nerve, basically.
Sort of, yeah. Myopathy is another that's disease of the muscle itself, not the nerve. And crucially, central nervous system disorders. Problems in the brain or spinal cord can sometimes mimic peripheral nerve issues.
So you need to look up the chain and at the muscles, too. It's not always straightforward. How common is this condition overall? What's the epidemiology say?
It's actually pretty common, especially as we age. The notes estimate something like 1 in 10 people over 55 might have some form of it.
1 in 10. That's quite a lot.
It is. And that figure goes way up if you look at people with those big risk factors, diabetes, heavy alcohol use.
Right.
Though the exact numbers do vary a lot depending on the population and the main causes in that group.
Okay. Let's talk about the clinical picture. What someone actually feels and what a doctor finds on examination. What are the key signs and symptoms listed?
Right. So based on which nerves are hit. For sensory nerves, it's often that classic numbness or tingling, starting distally, glove and stocking, loss of sensation touch, temperature, pain. If motor nerves are involved, you see muscle weakness, maybe even visible wasting atrophy. Coordination can be off. Patients might complain of burning or shooting pains or weird feelings like buzzing or electric shocks.
And on examination, what would a doctor specifically look for or test?
Well, during the neuro exam, they'd test sensations. Often find impairment, distally so, trouble feeling temperature changes, light touch, pinprick, vibration, and proprioception, that joint position sense.
Yeah.
Reflexes are often reduced or just absent, especially at the ankles, maybe knees. And in more advanced cases, you might actually see muscle wasting, particularly in the feet, along with that distal weakness.
And what happens if it gets really severe?
In severe cases, the impact can be major. The notes list serious balance problems, difficulty walking, leading to a high risk of falls.
Yeah, dangerous.
And, especially with sensory loss, a big risk of foot ulcers, because if you can't feel an injury, it can get infected easily.
That really highlights why management is so important. So if someone comes in with these symptoms, what investigations get done? How do doctors figure it out?
The investigations have a few main goals, according to the notes. First, find the underlying cause. We keep coming back to that because it's key.
Crucial, yeah.
Second, assess nerve function. How well are they actually working? And third, figure out the pattern and severity of the damage.
Okay, so what tests are in the toolbox?
It's usually a combination. Nerve conduction studies, NCS and electromyography, EMG, those are really important. They measure electrical activity in nerves and muscles.
Right, testing the wiring directly.
Exactly. Blood tests are vital too, screening for loads of causes, checking blood sugar for diabetes, vitamin levels like B12, autoimmune markers, full blood count, thyroid function.
The usual suspects.
Pretty much. Sometimes imaging, like an MRI, maybe to rule out other things like nerve compression. In specific cases, you might need a nerve or even a muscle biopsy for a definite diagnosis.
It's a biopsy, wow.
Yeah, or sometimes a lumbar puncture, a spinal tap, to look at the cerebrospinal fluid, especially if you suspect inflammation or infection. The notes mention NCS and biopsies can be particularly useful if symptoms come on really fast.
So, quite a workup, tailored to the person. Once it's diagnosed, what's the management strategy? What are the goals?
Management really focuses on three things. First, tackling the underlying cause, if possible. That's number one. Second, relieving the symptoms, especially the pain.
Which can be awful, yeah.
Definitely. And third, improving function and quality of life.
And how do they do that? What are the approaches?
It's varied. Medications for pain are often needed, not just basic painkillers, but sometimes drugs originally for epilepsy or depression, which actually work well for nerve pain.
Anticonvulsants and antidepressants, right?
Exactly. Physical therapy is huge, maintaining strength, balance, flexibility. Occupational therapy helps people adapt daily tasks if their hands or feet are affected.
Practical help.
Yeah. And lifestyle changes are critical depending on the cause. Strict blood sugar control and diabetes, stopping alcohol completely if that's the issue, avoiding toxins.
So it's much more than just medication.
Absolutely. The notes really stress regular monitoring and a team approach. Neurologists, pain specialists, physios, OTs working together.
A multidisciplinary team.
Precisely. It has to be individualized based on the cause and how it's affecting that specific person. And again, like with diabetes, ensuring someone takes their medication properly is a massive part of managing the neuropathy itself.
Okay. Looking down the road then, what's the prognosis usually like? What's the general outlook?
It really varies. Hugely depends on the cause, how bad the damage is when it's found, and how well everything is managed. There is good news for some if the cause is reversible, like fixing a vitamin deficiency or removing a toxin. The nerve damage can actually improve, sometimes significantly.
So some types can get better.
Potentially, yes. But for many chronic or progressive causes, the focus shifts more to managing symptoms, stopping it getting worse, and preventing complications. The notes do say complications can affect the long-term outlook.
Makes sense.
So really early diagnosis and sticking to the management plan are the best ways to optimize things for someone. Improve their function and quality of life as much as possible.
Let's zone in on those complications for a second. What are the main problems that can arise if it's not managed well?
The ones listed are pretty serious. Chronic pain is a big one, often really hard to treat effectively. Muscle weakness and wasting can become permanent.
Leading to disability.
Yeah. Impaired balance, mobility problems, these directly increase the risk of falls, which can have devastating consequences, especially in older people. And we mentioned foot ulcers before, a major risk with sensory loss, potentially leading to infections, even amputation in severe cases.
Those really underscore the potential severity.
They do. And the notes also remind us that the underlying condition itself, like uncontrolled diabetes or ongoing alcohol abuse, carries its own set of complications on top of the neuropathy.
Right, compounding the issue.
Exactly. So the bottom line here is that prevention where possible, good monitoring, and effective management are just crucial to cut down the risk of these complications and improve outcomes.
Wow. Okay, we have covered a lot of ground there, from the basic definition right through to prognosis and complications. We've really pulled apart those key points from the MSRA notes.
We really have. I think seeing that huge range of causes, understanding the motor versus sensory split, knowing those specific patterns like in B12 deficiency, and appreciating just how comprehensive the diagnosis and management needs to be, those are definitely the high-yield bits to take away.
And getting that clear picture of the symptoms, how they link to exam findings, and why nailing the underlying cause is so vital. It gives you a really solid framework for thinking about peripheral neuropathy.
Absolutely. Thinking about all those diverse causes, nutrition, immunity, toxins, metabolic issues like diabetes, it really highlights how interconnected everything in the body is. And makes you think, doesn't it, how much of the real challenge here, beyond the initial diagnosis, is actually the long game, that ongoing partnership between the patient and the medical team to consistently manage that underlying condition, like keeping blood sugar spot on in diabetes, to truly change the course of the neuropathy and stave off those serious complications. It's more than just pathology. It's about that sustained effort and adherence.